Hello, everybody. My name is Dr. Dan Driscoll. I'm a professor of pediatrics and genetics at the University of Florida College of Medicine, and I'm also chair of the Clinical and Scientific Advisory Board for IPWSO. And today I'm going to be doing a brief overview of newborn screening and a brief discussion of Prader-Willi syndrome and how it relates to newborn screening. And so my background is I'm a board certified clinical geneticist and pediatrician. I have 32 years of experience doing newborn screening, particularly in the state of Florida. And I served 10 years on the state of Florida's newborn screening committee. And one of our functions is to decide which new conditions to add. So brief overview, history of newborn screening in the US, and it's similar to Europe and Australia and other countries. So newborn screening began in the mid-1960s with PKU. Babies with PKU appear healthy at birth, full-term healthy baby. The baby goes home. The problem is PKU is an insidious condition that, if untreated, leads to intellectual disability. So it's silently destroying the brain. There's a toxic levels of phenylalanine and its products building up because the enzyme is missing for taking phenylalanine to tyrosine. So since the mid-1960s, newborn screening is mandatory in almost all the states in the United States. It's offered in all states, but there's a few states that allow parents to opt out. This is a rare occurrence, but it is done in all 50 states. And in fact, most parents are unaware that the newborn screening test was done. Some people still call the newborn screening test the PKU test, but this is incorrect because advances have been made. And now in Florida, we screen we can pick up 57 conditions on the newborn screen. 35 are what are called core conditions. In other words, these were the conditions that the various tests were developed to pick up on the newborn screen. However, some of these same tests pick up what are called, quote, secondary conditions. For instance, if there was a test to pick up Angelman syndrome as a core condition, as a PKU, Prader-Willi syndrome would be picked up as a secondary condition. And the screen in Florida contains all 54 of the recommended conditions by the US Department of Health Uniform Screening Panel, plus 3 other conditions. And states have the ability to add conditions that aren't on the US Department of Health's screening panel. To put it in perspective, Florida has 21.5 million people. This is a little bit less than the population of Australia. We have about 220,000 births per year and about 270,000 newborn screens done per year. The reason there's a discrepancy there is that some tests need to be repeated because of an unsatisfactory sample collection or ambiguous results. The state is divided up into 3 newborn screening centers. The University of Florida, where I'm at, we cover North Central Florida from Orlando north. Then there's the University of South Florida in Tampa that covers the southwest part of the state. University of Miami that covers the southeast part of the state. And there's 6 main classes of conditions on the newborn screen. Organic acidemias is one class, and this picks up conditions like propionic acidemia. Fatty acid oxidation disorders picks up conditions like MCAD. Amino acid disorder picks up conditions like PKU, phenylketonuria. And then there's endocrine conditions, picks up congenital hypothyroidism. Hemoglobinopathies pick up sickle cell disease and other hemoglobinopathies. And then there's a miscellaneous collection of other conditions. For instance, congenital heart disease, cystic fibrosis, enzyme disorders like galactosemia, hearing loss, and then the state recently added Pompe, spinal muscular atrophy, and Hurler syndrome. Now, the vast majority of conditions on the newborn screen share these core characteristics. The majority are metabolic conditions, inborn errors of metabolism. The other key point is the vast majority of these babies are normal, healthy appearing babies at birth. The babies typically go home with the mother. But if the condition isn't picked up quickly, missing and delayed treatment will lead to either death or intellectual disability. Most of them are, almost all of them are genetic, with a typical recurrence risk of 25%, reflecting a autosomal recessive condition where both parents are carriers but unaffected. But if they both pass the defective gene to the child will be affected. And so there's a 25% recurrence risk for most of them. The other common characteristic is that there has to be a gold standard test to confirm the screening results. Also, an excellent treatment that prevents death or intellectual disability. Treatments, for the most part, must be initiated within the first 1 to 2 weeks of life. Now, there's some rare exceptions to the above statement, but that's pretty much the standard, that we need to initiate treatment quickly. But the principle is that early treatment makes a substantial difference in the life of that child and prevents death and or intellectual disability. Now, there's over 6,000 genetic diseases that have genetic tests for, but we only screen 57. What are the steps in newborn screening? This is a very laborious process. It starts with newborn screening card collected by a heel stick at the birthing center, generally after 24 hours of life, after feeding has begun. Many of the conditions won't be picked up if the baby hasn't fed yet. The card is sent to the state lab in Jacksonville, Florida, and this can take 1 or 2 days, or longer if there's a delay from the birthing center getting it to Jacksonville. In addition, we're a long state, so Key West is about 8 hours driving time to Jacksonville. Then when it gets to the lab, it takes 1 to 2 days to run the tests, different tests for different diseases. The results are generally in 3 to 4 days after collection, which is generally 4 to 7 days after birth, and then communicated to one of the 3 main genetic centers I mentioned. And at this point, this is when dietitians, genetic counselors, and physicians like myself get involved. The first step is we contact the primary care physician to let him or her know the results and the next steps to collect the gold standard testing. And then the family is notified. This seems straightforward, but sometimes the wrong primary care physician is listed on the newborn screening card, or it's left blank. Sometimes the families are difficult to contact and track down. There's been a few cases where we've had to send the state police out to the family's house to make communication with them. But urgency is the name of the game. And then once we make contact with the family and the primary care physician, we arrange for the gold standard testing. Now, definitive results can take days to several weeks, depending upon the disorder. The inborn errors in metabolism, the metabolic tests generally just take a few days. And they're the ones that are typically most serious to make the diagnosis and get the right treatment going. This whole process is very labor intensive. And the other key point is that on the newborn screen, there's over 90% of false positives, meaning the baby is fine. The test was very sensitive and overcalled the result. And this, of course, can cause a lot of anxiety in families that think they have a normal, healthy baby and then be told, hey, your child could have a serious condition. And the final step that we do is arrange follow-up at one of the medical centers for treatment and genetic counseling. And again, remember, a lot of these conditions have a 25% chance of recurring in families. So the genetic counseling is very important. So families know their risk and know to be prepared with each pregnancy or have prenatal testing. So now I'm going to switch gears a bit and talk about newborn screening for Prader-Willi syndrome, Angelman syndrome, and duplication 15q. These are all conditions on the proximal end of the long arm of chromosome 15 that I'm sure you're all aware of. David Godler and colleagues recently published in JAMA Network Open about a screening test they had devised in Australia. And this is a very nice piece of work. I know that David is also giving you a talk, so I won't go into much detail. That will be his job. So just briefly, David and his colleagues screened almost 17,000 newborns in Australia. And by their initial surveillance, they had 92 positives by their DNA methylation, special DNA methylation analysis, which they call MSQMA. 5 were confirmed by gold standard testing to be truly positive. There were 2 individuals with Prader-Willi syndrome, 2 Angelman syndrome, and 1 maternal duplication 15q. Therefore, with that standard, they had about 95% false positives. Now, when they use more stringent criteria to call the positives, they only had 9, but they missed the duplication 15q when they made the more stringent threshold. With the more stringent threshold, then the positive predictive value for Prader-Willi syndrome was 33%. And this technique is based on DNA methylation analysis and should pick up greater than 99% of individuals with Prader-Willi, including deletions, maternal uniparental disomy, and imprinting defect. They all have a abnormal DNA methylation pattern. And so this illustrates the tug of war that we have in newborn screening between sensitivity and specificity. Generally, most newborn screens, certainly in our state, errs on the side of sensitivity. They don't want to miss any babies, but then that leads to more false positives. If they make the stringency very high, it can be very specific and have much less false positives, but you may miss a few babies with the more stringent criteria. And so the philosophy typically in newborn screening is to sacrifice specificity for sensitivity, picking up more babies. So how does a condition get on the newborn screen? There's over, as I mentioned, 6,000 genetic diseases, and newborn screening is very labor intensive. There has to be funding and support in place, including dietitians, genetic counselors, and physicians. There must be a compelling reason to put it on the newborn screen. For example, treatment that makes a significant difference if diagnosed, if initiated early. And strong advocacy helps. Our recent conditions, spinal muscular atrophy, and Pompe syndrome and Hurler syndrome, there was a lot of advocacy from the parents, hooking up with politicians, and then various physician champions in the state. However, at this point, we don't have the resources or infrastructure to screen for every possible condition for which there is a test. As I said, over 6,000 genetic diseases. And generally, the process is slow. A new condition doesn't get added to the newborn screen in a short amount of time. It can generally take 3 to 5 years to add a new condition. It took spinal muscular atrophy 10 years for the benefit of gene therapy to be demonstrated and then be decided to be added to the newborn screen. And not all the states in the United States have spinal muscular atrophy. New York was a pioneer in bringing this to the newborn screen. And an important point is false positives are very time consuming to the staff and disruptive to families. So we have to keep in the benefits and the risks when we add conditions. And finally, frankly, there's a shortage of trained staff, metabolic dietitians, genetic counselors, clinical geneticists. So Prader-Willi syndrome, talk about for just a couple minutes, is really almost unlike any other condition on the newborn screen. The clinical findings are almost always present at birth versus the other conditions on the newborn screen where the babies appear healthy and normal and get sent home with the mother. Babies with Prader-Willi are hypotonic and floppy at birth, and almost always physicians should recognize that there's something going on with this baby. This isn't normal. They'll also have poor feeding and a very poor appetite, won't be interested in taking the bottle or the nipple. And there typically is hypogonadism, both in males and females, more obvious in males, but still present in females typically. Feeding treatment is going to be initiated without a diagnosis. The baby's not feeding, is in the nursery, or has gotten transferred to the neonatal intensive care unit. Typically, a feeding tube will be put down the baby, nasogastric, orogastric, and feeding be done that way. Occupational therapy will get involved to help with the feeding. Genetics and neurology at most major medical centers in the United States, and certainly at this institution, we're going to be consulted in typically in the first week of life. Typically, I'm consulted in the first couple days of life with a hypotonic floppy baby. And then the diagnosis of Prader-Willi syndrome is suspected, and genetic testing, DNA methylation analysis will be sent. This diagnosis usually takes 2 to 4 weeks of life at most major medical centers in the United States. And growth hormone therapy will then generally begun in the first 2 to 3 months of life. So one of the key principles that I want to emphasize to you all and other physicians and people that take care of newborn babies is that all hypotonic floppy infants should be tested for Prader-Willi syndrome. There's a great test that my lab pioneered and introduced in the early 1990s that I'm sure most of you are aware of. DNA methylation analysis will diagnose greater than 99% of individuals with Prader-Willi syndrome. There's a number of labs in the country that will do this testing, and it typically takes 1 to 2 weeks. I think it's going to be difficult to get Prader-Willi syndrome on the newborn screen as a core condition in the United States at this point. In addition, we have to consider countries with limited health care that do not have the resources to add it to the newborn screen. There's many countries in the world that don't do any newborn screening or some that just do one or two conditions. For instance, in Africa, I believe there's some countries that just do sickle cell screening. And another thing just to keep in mind that's coming down the pike is non-invasive prenatal screening. So this is where you take a sample of the mother's blood, and there's fetal DNA floating around in the mother's blood called cell-free fetal DNA. And this can diagnose the major trisomies, trisomy 13, 18, and 21 Down syndrome. And various commercial labs are using it to diagnose deletions like Prader-Willi syndrome and Angelman syndrome. At this point, it's just picking up the deletions, which is about 70% of Prader-Willi. While non-invasive prenatal testing is very good for the trisomies, a whole extra chromosome, with the microdeletion syndromes like Prader-Willi syndrome, there is a lack of specificity. There's about 95% false positives. And of course, the labs are working on improving this specificity. And I think that will be coming in the future. I'll talk just a bit about Angelman syndrome in my final thoughts. In Angelman syndrome, there are several gene therapy trials that are beginning. And my feeling is if these are shown to make a significant improvement in children with Angelman syndrome, then this might be added as a core condition in the future on newborn screening panels. And then Prader-Willi syndrome would be picked up as a secondary condition because it's the same technique used to pick up both DNA methylation analysis. Prader-Willi only has DNA methylation from the mother, and then Angelman syndrome is lacking the maternal contribution. So the SNRPN locus, the locus we use, would be unmethylated. However, I think this is going to take many years at best to get on the newborn screening. And so what I would advocate in the interim is that we suggest advocacy in getting the word out through patient advocacy groups, parent support groups, physicians, geneticists, that all hypotonic floppy infants should have a DNA methylation analysis. And I think many geneticists and neurologists would agree with that. This test is widely available in the US and other countries. Countries with limited healthcare can send a sample to the Bird Institute in Italy that IPWSO sponsors, and this will be done for free for those families. And it can be done with a finger or a heel stick on specialized filter paper or a newborn screening card. And the final thing I'd like to remind everybody is that we're having our international meeting in July this year in Limerick, Ireland. I think we have a great program for clinicians and scientists, providers and families. And so I hope many of you will make the trip to Ireland. And thank you very much for your attention.